day of the HA forums, the National HA forums. From those who would like to have the translating device, we prepare for you in front of the room if you would like to. But if you would like to practice your listening, that's fine. Today will be a pretty long day for us. We have 4 sessions for this room. The morning will be 2 sessions about the managing infection risk in the 21st century, and then the measure the immeasurable. And then the afternoon time will be 2 more sessions about safety, journey, and healthcare IT development. Today's challenge, and the last session will be about transformation leadership in the very fast changing healthcare environment. This morning for the first session, managing infection risk in the 21st century, we have a pretty warm, pretty warm room because we have 3 speakers. It's very pressure for us to have 3 speakers on the stage. Another one is coming soon. Maybe she's go to the toilet. No? Many medical errors and healthcare acquired infection are caused by systematic management failure. Infection risk management standards should be available in all hospitals to ensure that infection risk is being managed effectively. In this session, concept, implementation, and success story in regard to infection risk management system will be presented by Dr. Paul J. Huntley, a Manager Director of Risken, no? Who are specialized in a management system approach to managing risk in scientific environment. He is a contributor in the development of the managing infection risk standard and rollout of the MIR philosophy and approach. Also joining the discussion to share experience on MIR, I would like to introduce the person who on the stage first. Dr. Montri Raksuwong, an experienced surveyor of HAI from Payathai Hospital. And also will be coming soon on the stage, no? Kun Chanya still on the way. Kun Chanya Charat Yopat, no? And Associated Division Director of Quality and Safety Management from Bamrungrad International Hospital also joined on the stage as well. So I think we're gonna start with Dr. Paul first.
Good morning. Try again. Good morning.
Good morning.
Good morning. Very nice to be back in Thailand again. Thank you, HA, for inviting us to give this presentation. So we have around an hour and a half this morning. I'm going to talk hopefully for about 40-45 minutes, and then Dr. Montri will talk on behalf of HA, and then Kunjunya, if she comes back again, will be talking about experience from Bumrungrad Hospital. And just before I begin, I'd like to introduce Ms. Tan Gekeng, who's in the front row here, who is the healthcare manager for DNVGL. So if you would like any more information about the standard, etc., please see Gekeng, or you're welcome to come to our booth. We have a copy of the standard in Thai. So if anyone would like a copy of the standard, please approach us afterwards. My name is Paul Huntley. I am Scottish. I live in Singapore, work all over the world with different people who handle infectious disease agents. A lot of my work is in hospitals. Some of my work is with big laboratories, people like World Health Organization. So last week I was training people on poliovirus and poliovirus controls. So my life really is working with organizations who either deliberately or just through the course of their work have to handle dangerous microbes. I've been working in this area for about 15 years, and some of the areas that I work in you might think are very high risk. So laboratories that handle smallpox, laboratories that handle Ebola, very high risk. Actually, they are not very high risk. They are major hazard, but the risk is very small. The chances of harm to the workers is low. The chance of harm to the community is very, very low. And I started working in hospitals maybe 7 years ago. One of the things I realized was the risk in hospitals is much, much higher than it is in these facilities. And the real risk in hospitals often is not MERS, it's not Ebola, it's everyday organisms that exist in the hospitals that have a huge impact on the patients. So what we did was we sat down and we said, okay, let's develop a standard for hospitals that looks specifically at infection prevention and control. And it might look at some of the exotic organisms, so SARS, etc., but really also focus on some of the simple things that cause real harm to ordinary patients every day of the week in hospitals all around the world. And that's what we've been trying to do with the Managing Infection Risk Standard. So it's a standard that sets out a management system. And management system can be a little bit dry, can be a little bit boring, but actually this one is, I think, quite interesting. And I'm going to talk about it today, not in a very formal management system way, but to try to explain what the standard tries to do, give you some examples of the areas that we discuss with the hospitals, and then most importantly, my friends and colleagues are going to give you their experience from a user perspective in Thailand. So both HA, who've been participating in some of the assessments, and Bumrungrad, who've been through this assessment, and we hope very, very soon will become the first hospital in Thailand to become a center of excellence for managing infection risk. So the objectives introduce the organization, DNVGL, a big international organization based in Norway who do a lot of work in healthcare. Talk to you about managing infection risk, give you some practical examples. And also, this is not such a serious presentation. So we're going to talk a little bit about the theme of the conference, because I think one of the very interesting things about the standard is it has been a very good tool for the hospitals in terms of communication, in terms of understanding management systems, etc., using infections as a theme. So we have a few photographs, etc., and a few different areas that we can discuss. Hopefully we will not take all of the time. So if anyone has any questions, we will be able to take the questions at the end. DNVGL, based in Norway, an organization which really is about managing risk in major hazard industries. So originally in maritime, but also in areas like oil and gas, nuclear. And one of the interesting things is that my belief is that these other industries are very small in terms of risk compared to healthcare. So as an individual, when you go to hospital, you are exposed to a significant level of risk which goes way beyond most of these other industrial environments. So what we try to do with MIR and other services is bring some of the knowledge from these other industries and apply it to healthcare, which is a very, very different environment. So if anyone tells you a hospital is just like an aeroplane, I think they are confused, because a hospital is much, much more difficult to control than an aeroplane, because you've got lots of people there with different conditions, different susceptibilities. You've got a very, very complex organization. But I believe you can still take some of these principles and apply them to healthcare without saying a hospital is an oil rig or a hospital is a nuclear facility. It's a very, very different environment. DNV, 151 years old, so quite an old organization. In terms of healthcare, actually one of the bigger organizations throughout the world. So a very large certification organization working with about 2,500 different healthcare organizations around the planet. One of the big accreditation bodies in the US, doing international accreditation also in a number of different countries. So there is a general accreditation service. There are a number of different ISO type standards which are of interest to the hospitals, so things like 9,000, 14,000, etc. But the specialized area that I work in is the control of infections. So the two major standards that we use most of the time, one is the International Accreditation Standard, which is very similar in nature to the JCI standards. But the one that I have been working with almost exclusively for the last few years is the Managing Infection Risk Standard, which complements accreditation. And some people ask us, why is there a special standard for managing infection risk? And the answer is really that this is a very specialized area. And during a major accreditation survey, there just is not the time and opportunity, and often not the expertise, to look at this area in really great detail. So we would say that during an accreditation survey, we would look at infection control under the magnifying glass, but during an MIR survey, we look at it under the microscope. So we really go in detail into the program, how it works, the results, etc., right down to implementation in the different areas which are important. And managing infection risk is based around 18 different elements. So the structure has been developed over a number of different years. Some of the elements are very technical. Some of the elements are very organizational. So the first element, which is really looking at organization, looks very similar in nature to a quality management system. But it's asking questions about policy, it's asking where people set objectives and targets, it's asking about internal audits, etc. And basically saying, are you an organization? Do you set consistent expectations? Do you look to see that these are met, etc.? Or are you a group of different departments, different individuals who may not be working together to meet the organization's objectives? So it's quite a big element, but focuses specifically on infection control. There's then another element which I think people have found very interesting, which is risk assessment. And risk assessment really looks at the way that people identify hazards and risks in the hospital, I think in a way which is slightly different to what has often been done before. So there's an expectation that there will be risk assessments, that they will be formalized, that they will be documented, and there are many, many different areas where you could do risk assessments. So one of the things the standard is doing is really, I think, starting a discussion in terms of what type of risk assessment should be done in healthcare, what techniques should be used, etc. Then we begin to get into the more technical elements. Some are about antimicrobials, some are about healthcare and vaccination, some are about the buildings, and I'm going to go through some of these in a little bit of detail as part of the presentation. But basically it's around 18 elements. It covers everybody and everything in the hospital. So if you're a receptionist, you're part of MIR. If you are a security guard, you are part of MIR. If you are a housekeeper, you are a critical part of MIR. Okay, so it's not just about doctors and nurses, it's not just about antibiotics and pharmacists, it's about everybody in the organization and the role that they play, and they must be formally part of this system. And the theme for the conference, we do, I think is very, very relevant to this particular standard because it really does involve and engage everyone. So the first element is the infection risk management system. Basically, the question you're asking is, are you an organization? Do you have consistent policies? Do you have control, etc.? So one of the first things it does is it says that in the hospital there is a leader, usually the chief executive. What is the chief executive's role in managing infection risk? So the standard takes this away from a technical discipline to an organizational responsibility. So in the first element, it asks lots of interesting questions about what is our policy? How do we try to have consistency? How do we try to implement good practice? How do we, in a structured way, set objectives and targets? And most importantly for the boss, how do we know that we have adequate resources for managing infection risk? So it's a very big element, but at the center of the element is this idea that this is an organization with leaders who will set consistent expectations, etc. And that can bring a certain degree of tension because some of the elements are quite clinical. So a very good example is antimicrobial stewardship. And basically you're asking the question, who decides what the policy should be on dispensing antimicrobials? And historically there has been usually a large degree of discretion in terms of what antimicrobials might be dispensed. And the standard is saying that our leadership says we should have policies and we should follow these policies. So some of the discussions for some of the hospitals are quite interesting in terms of, is this an organization where we set the rules and we monitor, etc., or is it an organization where people have tremendous discretion? And of course the truth is it has to be a balance between the two, but the formalization that comes through this particular element in terms of setting consistent expectations is really quite interesting. Another part of this element, which is very, very tricky, is the area in terms of contractors and suppliers. Because hospitals used to be an organization who employed everyone, and more hospitals are becoming organizations comprised of a number of different contractors. And it probably started with kitchens, then it went to security, but now you find in many of the hospitals, some of the contractors are key clinical elements. So dialysis, areas like CSSD, and I think this is something that may continue in the future. And managing contractors in many industries is known to be a very, very difficult thing. So the standard puts clear requirements to say, if you have a person who performs a job, we don't care if it's a physician, we don't care if it's a nurse, we don't care if it's a housekeeper, we don't care if they're employed. If it's a contractor, they must be competent in that particular position. And the way that you gauge competence and control competence for contractors is often different to the way that you do it for staff. And of course, one of the really tricky areas is how do you gauge competence in physicians? Because they have different mechanisms. They have credentialing, etc., which may be entirely appropriate, but the standard says if a physician is going to insert a catheter, are they competent? Have they been through the training in the bundles? Can they demonstrate they understand the equipment, the environment, etc.? So there's many interesting areas in the first element which asks about what type of organization is this and what is the focus in terms of managing infection risk. The second element is risk assessment, and there is an expectation that not only will risk assessments be done, but that the hospital will decide as an organization this is what risk means to us. This is when we will do a risk assessment, this is who will be involved, this is the technique that we will use, this is how it will be done, this is how it will be reviewed, this is how it will be updated. And there are many, many different areas where you might do risk assessments. You might do risk assessments on a building, you might do them on a bundle, you might do them on an emergency, you might do them to select PPE. And this has been an area which I think has been of great interest to the hospitals. How can we move away from what in many cases has been a fairly simple understanding of risk assessment to something which is maybe a little bit wider, that covers more areas, uses different techniques. And many of the hospitals who've been doing these risk assessments are reporting that they are seeing some significant benefits. So the risk assessment element is really there for infection risk, but it also applies to medication management. It can apply to falls, many, many different areas of patient safety. So it's one of the ways that the standard actually, although it focuses on infection control, people very quickly realize that some of these techniques, etc., can be applied to lots of different areas. This is an example of when risk assessment and risk management goes sadly wrong. So this was the MERS situation in South Korea. A very good example, if you read the reports, of how the risk management can fail catastrophically. So very, very big outbreak, very high profile, etc. Very damaging to the hospital, but most importantly, extremely damaging to the patients who were involved. And to be honest, these situations, they could often happen to any hospital. And a lot of risk assessment is looking at these simple things that can go wrong, that can prevent this going from a serious incident into a major crisis. So we get many of these instances at the moment. And the idea of risk assessment is that you use a preventive way of thinking to make sure that when you get one of these patients, they don't result in a major outbreak. Antimicrobial surveillance, antimicrobial use is a major part of the standard, looking at the way that people look for infections, but also select antibiotics, etc., in order to try to minimize the risk of resistance and make sure people get the treatments that they require. And Sir Alexander Fleming, I always like to use this slide because obviously he was Scottish. Many good things invented in Scotland, including antibiotics. So many, many years ago, during his Nobel Prize-winning speech, he said that people would need to be very, very careful, because if they're not very, very careful, they are going to have antimicrobial resistance. That was 1941. So I can't even think how many years ago that was. That must be, what, 80 years ago? Close to 80 years ago. We still have the same issues today. And what the experts say is we're running out of antibiotics. And it's not just the infections that we need to treat, it is the impact that this is going to have on general surgery, etc. Impact it's going to have on cancer care. So one of the things the standard looks at is to say, we all know this is important, but the standard is going to require that you really sit down and say, what does this mean to your organization? How are you going to control it? What is good practice? What are the current standards, etc., that people are following so that they have a formal system in place to control the use of antimicrobials. Emergency response and contingency planning is quite an interesting element also, because there are basically two types of emergency. Some are what I would call general emergencies, so something like a fire. Other ones are very much infection-related emergencies. So if you have a fire and you have isolation patients, if you have highly susceptible patients and you need to evacuate them, what will happen? If you have an outbreak in the hospital, what will happen? And very often there are some plans which are very, very high level. So a good example is that you have a MERS patient, and you have an isolation room, and you have a team. What happens if you get 2 MERS patients? What happens if you get 10 MERS patients? What happens if you get 50 MERS patients? So the element really looks at some of these areas and says, are we really prepared for what could happen? Or are we making some assumptions which may or may not be correct? And it's led to some very interesting discussions in the hospitals in terms of not just what are the types of emergency, but what could be the scale of those particular emergencies, and how would those be managed? Personnel and competence is looking at the way that people are recruited, the way that people are trained, but most importantly, that the people are competent. So competence is defined as your ability to perform the work in the workplace under the conditions that you will experience in reality. It's not sitting in a classroom listening to someone like me. It's not clicking on a computer to go through your average training. It is standing there beside someone who is uncomfortable and complaining and trying to do some very, very practical things. Areas of competence that are raised, which I think are interesting. Often nursing work in the role of a housekeeper. They need to use disinfectants. They need to do cleaning in some very, very critical areas. Have they ever been trained in these areas? We mentioned physicians. how do you detail physician competence? If it's a visiting physician who maybe only spends a few days in the hospital every year, do you have the same expectations as an employed physician? So basically it's about saying, what job do people do? Are the people trained, and can they demonstrate competence irrespective of their job title, irrespective of their normal role? And again, it extends into all the different departments and all the different people. Human factors, which are the behaviors, the attitudes. The classic human factor is hand hygiene. So hand hygiene is all about human factors. It's all about behaviors. It's about believing. Yeah, so one of the big problems with infections is that in many other industries where you have an accident, you have a bang, you have a crash, you have a fire. If you infect a patient with your hands, what happens? Nothing. 3 days later, you're sitting at home watching the television, and someone says, "Oh, I feel very warm." You have no connection to the accident, which makes it very, very difficult for people to understand how critical simple things like hand hygiene are. And this is all part of human factors. And when we talk to the hospitals, when we do the training, we say, how important is human factors? Everyone says 10 out of 10. And we say, how much time and effort and money do you spend on studying and improving human factors? Not very much. So again, there's an expectation that we don't only look at the operating room and the equipment and CSSD, we look at the way that we think,